Welcome to Roadie Wellness, where we explore all things health and self-care. Whether you're seeking mental clarity, physical fitness, or insight from students like you, we've got you covered. Welcome back to the Roadie Wellness podcast. I am Olivia, and I am joined here today by Dr. Warren Schwartz, a psychologist here at the University of Rhode Island, and he joined us today to talk about sleep and how it affects student life. So, how do you know so much about sleep?
Yeah, through research and practice, I read the empirical research, attend continuing education events, and learn from my patients. The clinical experience is really valuable. Our population is so specific that it has some unique characteristics that I've been able to learn about from them. So yeah, research, practice, and self-application.
Yeah, I think you can always learn the most from yourself, and especially observing your own sleep.
Yes.
So what are some common sleep disorders among college students?
So I like to think of this more in terms of problems rather than diagnoses or disorders, since we think of disorders as specific categories, and diagnoses often miss the nuance in common problems that we see. So I'll speak to it in terms of problems. The most common problem I think that we see with sleep in college students is sleep deprivation. And we don't characterize that as a sleep disorder itself, because sleep deprivation is often quote unquote voluntary. I use that term loosely, but a lot of our students are quite sleep deprived, and we know this through the empirical research, and I'll get to some of that a little bit later. I'll also say that variable sleep schedules pose a big problem for a lot of our students. So they're getting out of bed on some days at 6 or 7 or 8, and then on other days 10, 11 o'clock, and that has all sorts of problematic effects on their sleep. So those are two very common problems. We do see a lot of insomnia, and we'll talk some more about that later. Of course, we also see the whole panoply of sleep disorders in the DSM, but many of those are less common than the ones that I've mentioned so far.
Yeah, I can definitely relate to the sleep deprivation, unfortunately. With variable class times as well, with some people having 8 a.m.s and the next day having noontime start classes. It's very difficult to adjust to that, especially as a student. So
It sure is.
continuing from that, how does the quality, and not necessarily so much the amount, but like the quality of a person's sleep affect a person's well-being and health?
In some very important and even serious ways. Um, Sleep has many functions, including mood regulation, facilitating growth and recovery, augmentation of immune functioning, weight maintenance, blood sugar regulation, metabolism, clearing of waste from the brain, memory, overall cognitive functioning, athletic performance. I mean, we can go on and on, academic performance. We know that students who don't sleep well are more likely to drop out of school and perform poorly in school. It affects reaction time, many, many functions of sleep. And as I like to say, sleep is a rising tide that lifts all boats.
Hmm. I've never heard that expression before, but that's very interesting. It definitely seems like it affects a wide range of a person's health. I didn't even realize the extent.
It really does, and it's one of the three pillars, as we like to think of wellness, which are sleep, exercise, and nutrition.
To make sure college students get the amount of sleep they need and a good quality sleep, what are some recommendations that you have for students?
Yeah, so some of this I think I'll get to a little bit later when we talk about sleep hygiene and some other recommendations. But just some basic tactics. Getting to bed, obviously getting to bed at a reasonable time, and getting out of bed the same time every day are very helpful, and we'll talk more about that too. Put devices away for an hour before bed. have a good bedtime routine, a good wind down time where the lights are low and, maybe changing into sleeping clothes, some personal hygiene activities that people do before bed. We also say that not to, in general, do anything in the bed except for sleep and sexual activity. The bed is a place for sleep. It should be a sanctuary for sleep, and really, really not helpful to have the bed associated with these more activities that involve wakefulness. We'll talk more about insomnia and the particularities involved there. So these principles, while they do apply to insomnia, there are more specific changes that we make that we'll get to. But I will say again that college students are extremely sleep deprived. This is a real problem. The average college student sleeps about 6 hours a night, while the average person of college student age needs about 8.5 to function well. And I don't want everybody to think that they need 8.5. That's just the norm. We're on a bell curve here. You might not need 8.5. You might need 6. You might need 10. But 8.5 is the average. So it's a real problem. We try to focus on this and get the information out as well as we can. I also want to say that one interesting finding in the research is student athletes sleep even less than student non-athletes, and that obviously is highly problematic since they're so active and they really need that repair function.
I have a question going back to one of your previous points, talking about a good bedtime routine. So, do you know why that is like helps sleep and helps a person become more prepared to fall asleep?
Yeah, that's a good question. I think my answer to that is going to be that we're creatures of habit, and that conditioning is a very powerful uh, shaper of response for people. And what I mean by conditioning is associating one event or one set of stimuli with another, or one set of stimuli with a response. When when we set the stage for sleep, we're sort of reminding ourselves, our body and our minds, that that we're ready for sleep, and that can create a more relaxing response that's conducive for sleep.
Yeah, that makes a lot of sense. So, like, when you do that routine, your body knows it's prepared to go to sleep because of, it being in that routine.
Yeah.
That makes you, like, physically more tired and able to fall asleep easier.
Yes.
I just wanna make sure. And you also mentioned previously about sleep hygiene. Can you expand on that a little bit more? I've never heard that term before.
Yeah, so it's a creative term that applies to sleep. Sleep hygiene are basic sleep practices that we can employ to improve our sleep continuity and the amount of our sleep. It's a set of basic principles that facilitate sleep, like monitoring or decreasing caffeine use, upping exercise to increase sleep drive, having a bedtime routine, making sure the sleep space is comfortable and quiet, things like that to help promote good sleep. And sleep hygiene is often enough to help a lot of people. Just this kind of tweaking a bit of the environmental and behavioral aspects of around sleep, but it's not always helpful. It's one piece of the puzzle. It's not particularly helpful on its own for people with insomnia. There's usually more, much more needed than sleep hygiene, but for the average person, it's usually pretty helpful.
It wouldn't be a sleep podcast if we didn't talk about insomnia,
Right.
a very complex issue that a lot of students face. So, yeah, is there any hope for insomniacs?
There absolutely is. So first, I just want to define insomnia clinically. We define insomnia as difficulty sleeping when a person wants to sleep, to the extent that they're awake for at least 30 minutes when they're trying to fall asleep or stay asleep, or if they're waking up too early before their alarm goes off. And that this happens on more nights than not in the course of a week, and that this has been going on for 3 months or more. So that's the DSM criteria for the diagnosis of insomnia. And we refer to this as chronic insomnia, which is different than acute insomnia. Acute insomnia happens to everybody. It usually resolves on its own within the course of 2 to 3 or 4 nights, often is associated with some major stressor that a person has experienced, it, maybe a trauma, maybe a breakup, a death, any sort of serious stressor that presents itself in a person's life. Also, we see acute insomnia with bipolar mania, which is a whole thing of its own. But typically, when we think of insomnia, we think of the chronic form of it.
Yeah, so then talking about chronic insomnia, to be specific, how is it typically treated? Is there different therapies, medications? What are some best practices, I guess, when it comes to treating insomnia?
Yeah, that's an excellent question. So, there is a therapy called cognitive behavior therapy for insomnia, and CBTI. And that is the recommended first line approach for insomnia, as recommended by the American College of Physicians. The efficacy is extremely high, higher than medication, and we see continued improvements with this therapy even 10 years after the treatment ends. So it's very robust and it lasts for a long time. It's the most effective therapy that I'm aware of. So medication sometimes is used for insomnia, sometimes not in the best way, but sometimes it's appropriate. It can help for acute insomnia, insomnia that hasn't been going on for a while, like I spoke to before, where there's this stress-based difficulty sleeping. Medications are not usually, almost always, indicated for a long period of time. The research for these medications does not indicate that they're effective for long-term use. Many of them lose effectiveness over time. Some medications disrupt the sleep architecture, and many people who use these medications feel a hangover-like effect the next day. So, what's the point of getting better sleep when you don't really feel good the next day anyway? So CBTI is the first line approach. It's extremely helpful, and it's one that we typically practice.
Yeah, I don't think anyone wants to take medication to feel hangover effect the next day. Like you
Right.
said, that completely nullifies the reason for good sleep.
It
So,
does.
so you mentioned CBT therapy, the cognitive behavioral therapy. Can you talk more about that?
Yeah, so CBT for insomnia
Oh,
is a little bit different than typical CBT that's provided to people with depression, let's say, or anxiety. CBTI is much more behavioral. There's a If we spelled it out, the C would be small and the B would be bigger. It involves 5 components, essentially. The first one is what we call time in bed restriction, and it's counterintuitive. Why would you restrict the time in bed for someone who's having difficulty sleeping? The reason for that is that insomnia really we can define as poor sleep efficiency, which means that the amount of overlap between the amount of time they're spending in bed and the amount of time they're sleeping is low. And we find that people don't really need more sleep. What they need is less time in bed, which is a very strange way of thinking about it, but very true. So what we do is we try to squash their sleep opportunity. I like to explain it to students as if we take a piece of clay or silly putty and we roll it out on the table into a long, thin rope and we pick it up, it's going to break. What we like to do is smash it together and then roll it out into a thick, shorter, but a thicker rope where the quality of the sleep or the continuity of the sleep is solid. The person's not having difficulty falling asleep. They're not having difficulty staying asleep. So we restrict time in bed. The second principle involves circadian rhythm. Circadian rhythm is the biological clock that regulates the sleep wake cycle. It involves all sorts of physiological processes that either keep the person awake or facilitate sleep. And we find that with circadian rhythm, that there's a circadian rhythm disturbance that often factors into insomnia. And part of the problem often is this irregular time out of bed that we touched on before, getting out of bed sometimes at 6 a.m., getting out of bed at 11 o'clock. When that happens, the biological clock isn't working as it should. It actually turns into more of one of those Salvador Dali clocks. I don't know if you've seen those,
Yes, I have.
the melted, distorted clock, and the body doesn't know what to do. So one aspect of CBTI is making sure that that person's getting out of bed at the same time every day. We're also trying to help them get into bed at the same time every day, but that's less important. We definitely don't want them to be going to bed too early because we want to compress that time in bed. The third principle is what we call sleep drive, which is no different than hunger drive or sex drive. The more you go without something, the more you need it or want it. So we want to increase sleep drive through exercise and also through by getting that person out of bed the same time every day. Not only helps set the circadian rhythm, but it provides an opportunity for a building of sleep drive throughout the day. If they're getting out of bed at 7 o'clock every day, they have all of that time. And I think of it as a balloon that fills with air throughout the day. And that balloon is nice and tight and tense by the time that person goes to sleep, and then it can discharge throughout the night. So sleep drive is important. The fourth aspect of CBTI is conditioning. We talked a little bit about conditioning before. We want people to associate the bed with sleep and nothing else. And so we ask them not to do anything in the bed except for sleep. We make the exception for sexual activity. So if they're not sleeping, if they're tossing and turning, we ask them to get out of bed. If they have homework to do or they want to scroll or they want to watch videos, that shouldn't happen in the bed. Nothing should happen in the bed, really, except for sleep. And then the last component is the sleep hygiene piece, which we already talked about before. The main action of this approach is in the time in bed restriction and the circadian rhythm and sleep drive functions. I want to suggest that people don't go ahead and try this on your own. Please see an expert because there are risks if you do it on your own. Please consult with an expert and we can help you with your insomnia.
Wrapping up the conversation on insomnia, is there a specific cause that causes chronic insomnia? I know you mentioned acute insomnia can be caused by situational factors and stressors in a person's life, but is insomnia caused by maybe something more long term, like anxiety or depression and another mental disorder or something else, maybe genetics?
Those are good questions. We think of chronic insomnia as being multi-causal or caused by multiple factors. One can be predisposition. So if someone has a predisposition toward negative hyperarousal, as we see in anxiety, they may be more likely to develop insomnia, but it's not the anxiety itself that can explain all of the insomnia. Again, conditioning is important. A person who develops chronic insomnia, we see almost always has ended up with a conditioning process where they've associated the bed with being awake. And over time, the bed becomes this place of frustration and this sort of battleground where they're almost expecting not to sleep. And then they become more anxious and then more anxious about sleeping. And so that sort of takes on a life of its own. So while a person with anxiety might be more likely to go that way, it's the conditioning itself that takes on a life of its own. So, and similarly with depression and people who are plagued with negative thoughts and concerns about their value, that too isn't normally sufficient to explain chronic insomnia. So another aspect of insomnia or causal factor of insomnia is the behavioral changes that people typically make when they have acute insomnia. People often try to adapt to the acute insomnia by doing all sorts of things that make sense, but that end up making it worse. And some of those things might be extending their time in bed to try to get more sleep opportunity, which then just means that they're awake in their bed for longer periods of time. Or they might feel fatigued, and so they might cut back on their exercise, which then reduces sleep drive and reduces their ability to sleep at night. They might sleep in, they might nap. All of these things can cause a more chronic form of insomnia. And then, of course, they start to get frustrated, and the anxiety associated with sleep makes the insomnia even worse and more chronic.
All right. Well, thank you for joining us today.
Thanks, Olivia.
Before we wrap up, a quick reminder that all information shared in today's podcast is for informational and educational purposes only. Thank you for listening to another episode of Roadie Wellness. If you like what you heard today, tune in every Tuesday on all podcast platforms for more. If you want to stay up to date on events and healthcare tips, please follow us at URI Health Promotions on Instagram. And if you have any ideas for future podcast episodes or more social media content that you'd like to see, please feel free to DM us or email us. Until next time, take care and stay healthy.